Hello, hi everyone. Welcome back to your channel, Hello Pharmacology. In this session, let us learn about a very important topic, that is the cell wall synthesis inhibitor. So let us see what are all the cell wall synthesis inhibitor that we have under pharmacology. So as you can see here, so all the cell wall synthesis inhibitors are, please remember, bactericidal in nature, bactericidal in nature. So they have a ability to kill the bacteria. They have ability to kill the bacteria. So under cell wall synthesis inhibitor, we have mainly penicillins, cephalosporins, aztreonam and carbapenems and the vancomycin. So here you should remember that so these four, they belongs to beta lactams, whereas vancomycin belongs to glycopeptides. So these are the cell wall synthesis inhibitor. So let us see in detail what are the examples for the other cell wall synthesis inhibitor. So cell wall synthesis inhibitor can be classified into beta lactams group and the others. So under beta lactams you have got penicillins, cephalosporins, monobactam, carbapenems and the beta lactamase inhibitors. So as you can see here the penicillins can be again classified into beta lactamase resistance penicillins, and next we have beta lactamase sensitive. Under that you have a natural penicillins, amino penicillins and a extended spectrum of penicillins. So as you know, second group is the under beta lactam cephalosporins. The monobactams example is aztreonam and carbapenem example is imipenem. So even when the person is allergic to other penicillin group, it is only the aztreonam doesn't show the cross sensitivity. So in the patient who are having allergic to beta lactam group of antibiotic, the exception here is the aztreonam. So if the person is allergic to penicillin, you cannot be using a cephalosporins or carbapenems except for aztreonam, which has not shown the cross resistance. So under carbapenems you have got imipenems. Under beta lactamase inhibitors you have clavulanic acid, sulbactam and tazobactam. So the other antimicrobial agent which also inhibits the cell wall synthesis inhibitor are glycopeptides. Under glycopeptides you have a vancomycin and the talavanacin. Under lipopeptidase you have got daptomycin. Under non-classified group of drugs you have got bezitracin and cycloserine. So these are all the cell wall synthesis inhibitor. So let us move on to penicillins. So as you can see, so what is the mechanism of penicillin? So mechanism of penicillin, you need to remember these three things, a very important. Please remember, it binds to penicillin binding protein. So the target site of penicillin is the penicillin binding protein, which is located in the cytoplasmic membrane. So in your exams, they may direct or they may mark the target in the cytoplasmic membrane, and they may ask which antimicrobial agents will going to target the penicillin binding protein, or they may ask penicillin binding protein will act on the which membrane. It is not a cell wall, it is, remember, it is cytoplasmic membrane. So they bind to the plasma penicillin binding protein, which is located in the cytoplasmic membrane. Further, after binding, they prevent the transpeptidation, so which is required for cross-linking of the peptidoglycan chains. So first they bind to penicillin binding protein, they prevent transpeptidation, finally they inhibit the cross-linking of the bacterial cell wall. So this is the basic mechanism of almost all the cell wall synthesis inhibitor. So next, coming to, let us understand. So as you can see here, there are pores. These are the lipid bilayer membrane. So this is the outer membrane and this is the peptidoglycan. So this is the cell wall actually. This is the cell wall. This is the cell wall. And here you can see the periplasmic space, and you have a cytoplasmic membrane. So on the cytoplasmic membrane you have a penicillin binding protein. So initially what happens, whenever you give a penicillin, this is the penicillins. So these penicillins will enter through the pores. So from the pores, following that, it will reach a periplasmic space. From the plasmic space they will going to attach to the penicillin binding protein. So they have a receptor domain on the penicillin binding protein. They will combine and they will going to weaken the cell wall synthesis. They will going to decrease the peptidoglycan formation. So here one of the interferences, if the resistance can be developed due to the beta lactamase activity. So once the beta lactamase activity is there, so it will break down the whatever the penicillin is coming in, and it leads to what? It leads to the decreased efficacy of the penicillin. So coming to the pharmacokinetic parameters of the penicillins. So most of the penicillins are excreted unchanged. Please remember, most of the penicillins are excreted unchanged through the kidney, that is through the filtration as well as the secretion. So since it is excreting through the kidney, so the dose adjustment has to be made in case of renal dysfunction. So the exception for this is so the neficillin, oxacillin and dicloxacillin. So please remember, neficillin, oxacillin and dicloxacillin, they are excreted through biliary excretion. So they can be used safely in case of the renal dysfunction because the neficillin, oxacillin and dicloxacillin excreted through biliary secretion. So that means they are lipid soluble in nature. So that means the most of the penicillins, since they are excreted unchained through kidney, so they must be more of water soluble in nature, whereas these drug neficillin, oxacillin, dicloxacillin, since they are excreted through biliary excretion, they are more of lipid soluble in nature. So coming to the resistance mechanism, as you can see the diagram, diagram here. So the resistance can develop either due to the mutation in the purines, or due to the increased beta lactamase activity, or due to the alteration in the penicillin binding protein. So these are some of the important major mechanisms. As you can see here, one is the due to the beta lactamase activity itself, and next is there's a mutation in the penicillin binding protein. So the example is the methicillin resistance. So second cause is the mutation in the penicillin binding protein. So there may be down regulation of the porins, and there may be fourth cause is the upregulation of the efflux pumps. So efflux pumps, what they will do is they will going to throw out the penicillins which has been entered inside. So they basically the efflux, they will going to throw the penicillin out of the cell. So as you can see, in case of methicillin resistance, which is the drug of choice we are preferring. So in case of methicillin resistance, drug of choice will be your vancomycin. Vancomycin is the drug of choice in case of the methicillin resistant staphylococcus. So these are the different ways by which resistance can develop. So there are four ways. One is by the beta lactamase, second one by the mutation in the penicillin binding protein, down regulation of the porins, as well as the upregulation of the efflux pump. So beta lactamase will going to act on this structure. So here this is the structure. They may ask in your exams, so showing the structure, so which is the beta lactamase inhibiting site, beta lactamase acting site. So this will be your acting site. So if you change this R site, they are going to get a various different types of penicillins. So coming to the adverse effects of penicillins. So generally the penicillin is known to cause a hypersensitivity reaction. So among the antimicrobial agent, it is the penicillin which is going to have a most common hypersensitivity reactions. So apart from that, it also possesses a most common GI upset. Among the GI upset, the most common being a pseudomembranous colitis, which is shown by the use of ampicillin, and the most organism which is responsible for the pseudomembranous colitis is Clostridium difficile. So what will be the drug of choice? So if you have a metronidazole in the choice, so metronidazole will be the drug of choice. If metronidazole is not there, you can go for the vancomycin. So apart from that, you may experience a skin rashes in a patient who has been prescribed with the penicillin or amoxicillin. So please note that the skin rashes following the ampicillin and amoxicillin may not be a penicillin allergic reaction. It is not an allergy, but it can occur while you are using a ampicillin or amoxicillin to treat a viral illness. We don't know whether it is a bacterial or a viral infection. So empirically, you have chosen ampicillin and the amoxicillin. So while treating that, so in case of if it is a viral infection, especially the mononucleosis, the person may have a skin rashes. So ampicillin and amoxicillin can be used for empirical treatment. So apart from that, let us move on to the what are the penicillin additives we have. So there are two penicillin additives you need to remember. Those are the beta lactamase inhibitor. So please remember, by adding a beta lactamase inhibitor, you'll be enhancing the activity of the penicillins. So how do you enhance the activity of penicillins? By giving a beta lactamase inhibitor, like we have a clavulanic acid, which is a prodrug. So here is an interesting fact. So it is called as a suicide inhibitor. So beta lactamase inhibitors are also called as suicide inhibitors. The reason being, so if you take a prototype drug as clavulanic acid, to get metabolized to its active metabolite, so it requires a beta lactamase activity, and the active metabolite which is produced, it is the one which will going to inhibit the beta lactamase activity. So that is the name why they are called as suicide inhibitors. So there are suicide inhibitors of beta lactamase. So what are the other beta lactamase inhibitors we know? So apart from clavulanic acid, we have sulbactam, tazobactam. These are the three beta lactamase inhibitor you should remember. One is the clavulanic acid, sulbactam and tazobactam. So second way of enhancing the penicillin activity is to administer probenecid. So please remember that probenecid is a uricosuric agent. It blocks the penicillin secretion into the urine. It blocks the penicillin secretion into the urine through the proximal convoluted tubule. Thereby, what happens to the penicillin concentration? Penicillin concentration will increase. Penicillin concentration will increase. Penicillin concentration will increase. So that what will happen is that basically they're going to increase the concentration of penicillin. So by increasing the concentration of penicillins, you're going to increase the off-life of the penicillins. So there are two things to remember, the additive ones. So additive ones, you have adding beta lactamase inhibitor as well as the probonacid. So next, coming to the natural penicillins. So these natural penicillins are also called as beta lactamase sensitive narrow spectrum penicillins. They act on a specific organisms. So here penicillin G, if you take, it is a drug of choice in the treatment of syphilis. And we have a benzathine depot also to prolong the duration of action of penicillin in the form of depot preparations. And next we have a penicillin V. This has been only used particularly for specifically for group A streptococcal infections. Next we have a beta lactamase resistant penicillins. So under beta lactamase resistant penicillins, so these type of penicillins are also called as the anti-staphylococcal penicillins. Under this we have a methicillin. So methicillin is a prototype drug. So please remember, it is not used nowadays. The reason being, methicillin is used to cause interstitial nephritis. So it is the reason for which the methicillin has not been used nowadays, and only it has been used for laboratory testing to determine whether it is a methicillin sensitive staphylococcus or a methicillin resistant staphylococcus. So apart from that, we have other beta lactamase resistance penicillins like nefacillin, oxacillin, dicloxacillin. They are also effective against staphylococcus aureus. Basically, these drugs will going to eliminate it through biliary route. Nefacillin, oxacillin and dicloxacillin. So under this, let us see if the bacteria is resistant to methicillin. It is called as methicillin resistant staphylococcus. So in case of methicillin resistant staphylococcus, you are going to give a drug that is vancomycin. So vancomycin will be your drug of choice in case of methicillin resistant staphylococcus. So if the vancomycin is also not effective, then the drug of choice is, in case of vancomycin resistant staphylococcus, your drug of choice will be your linezolid. And also you can give combination with quinipristone as well as the dalfopristone. Next, coming to the aminopenicillins. So aminopenicillins, they are called as beta lactamase sensitive broad spectrum penicillins. Please remember, it is a broad spectrum penicillins. Under this you have ampicillin and the amoxicillin. So ampicillin is active against, since it is a broad spectrum, they will be active against both gram positive and gram negative organisms. And since they have got poor oral absorption, they are given through IV route, and they are preferably for empirical treatment when the treatment of Listeria meningitis. So as you can see that ampicillin was known to cause a non-allergic rashes with a viral illness, especially when treating in the form of empirical treatment. So especially in case of infectious mononucleosis, but it does not mean that it's a cross sensitivity towards a penicillin allergy. And even though there is a non-allergic rashes, you can use the ampicillin subsequently. So apart from that, coming to the amoxicillin, amoxicillin has got excellent oral absorption. This has been used in the treatment of otitis media, community acquired pneumonia, and sinusitis. So basically, amoxicillin is used along with the clavulanic acid to increase its efficacy. As you know, the clavulanic acid is a beta lactamase inhibitor, and also since it has got oral absorption, and also the diarrhea chances are decreased. So diarrhea is less with respect to the amoxicillin. So next, coming to the anti-pseudomonal penicillins. So and under anti-pseudomonal penicillins, these are the extended group of penicillins. So we have two drugs, those are carboxypenicillins and uridopenicillins. Under carboxypenicillins, you have got carbenicillin, you have got ticarcillin. So please remember, so under carboxypenicillins, you have got carbenicillin and ticarcillin. So they are most effective against the treatment of methicillin resistant staphylococcus, pseudomonas, and klebsiella. So apart from treating the MRSA, they are also effective against the gram-negative organisms like pseudomonas and klebsiella. Whereas the uridopenicillins, we have piperacillin. So piperacillin. So under uridopenicillins, we have a piperacillin. It is most potent penicillins against the pseudomonas. So it is anti-pseudomonal penicillins. So which is the anti-pseudomonal penicillins? It is your uridopenicillins, that is piperacillins. So it can be combined with the tazobactam for more effectiveness. Piperacillin can be combined with the tazobactam. So this was about the short class on the cell wall synthesis inhibitor, as well as the complete brief review of the penicillin group of drugs. So hope you have enjoyed this session. If you like this session, please do subscribe to my channel, I Love Pharmacology, and do not forget to share and hit the like button for more updates on pharmacology. Thank you.